Hi, I'm Dr. Marty Weiser. I am a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center. My interest and expertise is in intestinal cancers, including colon, rectum, small bowel, and appendix. What is total neoadjuvant therapy for rectal cancer and which patients should undergo it? Generally, we're talking about locally advanced rectal cancer. These are mid to low rectal tumors below the anterior perineal reflection, which is usually about 12 centimeters from the anal verge. And these are tumors that extend through the rectal wall and or involve local regional lymph nodes in the mesorectum or lateral pelvic sidewall. The concept is to change the sequencing of treatment and move all chemotherapy and radiation upfront before surgery. The benefits of total neoadjuvant therapy are early exposure of micrometastases to effective oxaliplatinum-containing chemotherapy, such as FOLFOX or CAPOX, improving the chances for non-operative management of rectal preservation, which is often called watch and wait, and it reduces the time that patients have a diverting ileostomy, since we don't have to wait for adjuvant chemotherapy to complete before closing the stoma. Therefore, the majority of patients can have their stoma closed in 6 to 15 weeks rather than waiting 24 to 30 weeks. Now, if we look back 40 years, the largest problem with rectal cancer was local recurrence. Remember, 1/3 of patients with rectal cancer suffered local recurrence following surgery. And local recurrence is difficult to treat, generally not curable in the majority of patients, and surgery is associated with significant morbidity and loss of quality of life. If we go back to NSABP-R01, this was a prospective randomized trial comparing rectal cancer surgery to rectal cancer surgery with postoperative chemotherapy and rectal cancer surgery with postoperative radiation. Local recurrence rates in the surgery group was 25%. This was reduced to 16% with the use of postoperative radiation, a tremendous improvement. Now, chemotherapy did not reduce local recurrence, but it did improve disease-free survival. The gastrointestinal study group, or GITSIG, had a similar study showing similar findings. And NSABP-R02 showed that if you add chemotherapy to the radiation, you could further improve local recurrence rates. The North Central Cancer Treatment Group, or NCCTG, showed that the addition of chemotherapy to postoperative radiation resulted in a 46% reduction in local recurrence and a 37% reduction in distant recurrence. This led to the NCI Consensus Conference in 1990, saying that the standard treatment for rectal cancer should include rectal cancer surgery followed by chemoradiation. Now, interestingly, in Northern Europe, they also made progress in rectal cancer treatment, but a little differently. Rather than using long course radiation or chemoradiation after surgery, they were using short course radiation delivered over 5 days, followed by immediate surgery. They also found a significant reduction in local recurrence from 27% to 11% in the Swedish rectal cancer trial. This was associated with improvements in overall survival. Also during this time, the idea of total mesorectal excision or anatomic resection was being popularized and taught throughout the world. And this is the concept that regional spread of rectal cancer is generally confined to the mesorectum contained by the visceral layer of the endopelvic fascia. And it's also associated with the idea that the circumferential radial margin is as or more important than the distal radial margin. The impact of anatomic resection is well shown in tumor registries from Stockholm, Norway, and the Netherlands, where you go from double-digit local recurrence rates to single-digit local recurrence rates, 14 to 16%, down to 6 to 9% with good surgery. And it was the Dutch rectal trial that said, in the setting of TME surgery, do you still need radiation? This prospective randomized trial compared patients with TME surgery to short course radiation and TME surgery, and there was still an improvement by the addition of radiation to good surgery. Local recurrence rates went from 11% in TME to 5% in the group that got TME with preoperative short course radiation. However, the preoperative radiation was associated with significant rates of fecal incontinence, and this is the cost of radiation. Now, the next important trial is the German rectal cancer trial. This was performed in Central Europe using the chemoradiation paradigm that's also used in North America. And this trial compared preoperative chemoradiation to postoperative chemoradiation. Local recurrence rates decreased from 13% to 6% when the chemoradiation was given before surgery rather than after surgery. And importantly, there was a significant reduction in toxicity when the chemoradiation was given before rather than after surgery. Now, interesting, if we look at the German rectal trial, not by intention to treat, but actually treatment received, the patients that fared the best received preoperative chemoradiation, and the patients that fared the worst got no postoperative chemoradiation. These were patients that were randomized to the postoperative group, but never received treatment, probably because of delayed recovery from rectal cancer surgery or complications. And this brings up the important idea that treatment is generally better tolerated when given before rather than after surgery. But the German rectal trial made standard in Central Europe and North America that chemoradiation should be delivered before surgery and adjuvant chemotherapy after. So why change to total neoadjuvant therapy? It's really based out of the realization that although local recurrence has been reduced to 4 to 6% from 25%, distant failure rate remains about 30%. And possibly this is related to the intolerance of adjuvant chemotherapy. EORTC 22921 was a 4-arm study looking at locally advanced rectal cancer patients that received preoperative radiation, preoperative chemoradiation, preoperative radiation and adjuvant chemotherapy, and preoperative chemoradiation and adjuvant chemotherapy. Now, the part of the trial that I want to discuss is the poor compliance of adjuvant chemotherapy. That is the tolerance of chemotherapy after rectal surgery. 60% of patients did not receive the prescribed postoperative chemotherapy, and 25% received no adjuvant chemotherapy. Again, this is likely due to difficulty recovering from surgery or complications. The other driver of total neoadjuvant therapy is the developing paradigm of non-operative management or rectal preservation. This is sometimes called watch and wait. Now, in total neoadjuvant therapy, chemotherapy such as FOLFOX or CAPOX can be delivered before or after radiation. If many people deliver FOLFOX or CAPOX before radiation for the perceived benefit of better compliance. However, there was concern that delayed chemoradiation could result in progression of the primary tumor, but we have learned from retrospective studies, mainly in stage 4 patients, that the primary tumor responds to FOLFOX and CAPOX quite well. And this is actually the topic of the PROSPECT trial. A Spanish phase 2 trial looking at locally advanced rectal cancer studied total neoadjuvant therapy to more standard chemoradiation surgery and adjuvant chemotherapy. And this study showed that treatment completion was significantly higher in the total neoadjuvant group compared to the more standard treatment group, 91% versus 54%. And the toxicity was less, 19% in the total neoadjuvant group compared to 54% in the standard group. We presented a retrospective series of rectal cancer patients treated at Memorial Sloan Kettering Cancer Center from 2009 to 2015. And we compared a group of patients treated with standard chemoradiation surgery and adjuvant chemotherapy to total neoadjuvant therapy. 320 patients in the standard group and 410 patients in the total neoadjuvant therapy group. And similar to the Spanish study, we found less dose reduction and better tolerance of chemotherapy with patients receiving or patients more likely to receive the prescribed chemotherapy in the total neoadjuvant therapy group. In addition, complete response rates were higher in the total neoadjuvant therapy group, about 35 to 40%, compared to 20% in the standard chemoradiation surgery and adjuvant chemotherapy group. And in fact, in clinically stage 2 patients, over 50% of patients had a complete response with total neoadjuvant therapy. The added benefit was earlier stoma closure. In the total neoadjuvant therapy group, over 80% of patients had their stoma closed within 15 weeks, compared to 20% in the standard chemoradiation surgery adjuvant chemotherapy group. Well, does TNT improve recurrence-free survival or overall survival? Since the main driver of TNT was to treat early micrometastases. And 2 prospective randomized trials were recently reported at ASCO 2020. The Rapido trial in Northern Europe used short-course radiation. These were bulky, locally advanced tumors that either had T4 disease and 2 disease, lateral node involvement, involved mesorectal fascia, or extramural vascular invasion. And patients were randomized to short-course radiation with consolidation FOLFOX-CAPOX followed by TME surgery, or more standard chemoradiation, TME surgery, and adjuvant FOLFOX and CAPOX. Disease-related treatment failure was significantly lower in the TNT group, 24% compared to 30% in the standard group. And 3-year distant metastases rate was 20% in the TNT group compared to 27% in the standard treatment group. The second trial was Protégé 23. This included clinical T3 or clinical T4 rectal cancer patients. And they were treated with the triplet FOLFOXIRI, followed by chemoradiation, TME surgery, and adjuvant FOLFOX, versus chemoradiation, TME, adjuvant FOLFOX. In the TNT group with FOLFOXIRI, there was a lower rate of 3-year disease-free survival and 3-year distant metastases-free survival. The 3-year disease-free survival was 76% in the TNT FOLFOXIRI group compared to 69% in the standard group. The 3-year distant metastases-free survival was 79% in the TNT FOLFOXIRI group compared to 72% in the standard group. At ASCO 2020, the OPRA trial was also reported, and this is a rectal preservation study that compared 2 different regimens for rectal preservation, either chemoradiation followed by FOLFOX-CAPOX or induction FOLFOX-CAPOX followed by chemoradiation. And in both groups, rectal preservation was over 50%. Interestingly, patients that received chemoradiation with consolidation, FOLFOX or CAPOX, had a higher rate of rectal preservation, indicating that the sequencing may be important. So TNT has become quite popular because better tolerance and earlier exposure of micrometastases to effective chemotherapy. And we now have, at least in abstract form, studies showing improved disease-free survival. There's also improved chances of non-operative management or rectal preservation or watch and wait And also patients have reduced time with diverting stomas. It's because of these reasons that TNT has become our standard treatment protocol for locally advanced rectal cancer.